want to welcome everybody who's hopefully watching this by video to sort of give everybody a bit of a rundown on sort of our program here at the University of Washington / Harvard Medical Center. Used to doing this more in person, and so then we can have sort of live questions. I'm sure some questions will come up after you watch this, and so hopefully you're watching this before we do our Zoom interview. And so as questions come up, please write them down, or things that seem inconsistent or unclear, or things you've heard differently. And of course, cross-reference that too as you talk to our fellows, talk to other faculty. We really want to try and provide an honest perspective on our program, who we are, what we offer. We realize we're not the right fit for everybody. We are the right fit for some people, but again, want to do no false advertising, but really present us as we are. So in our current model, the way our program runs, you would be rotating through, at this point, 3 hospitals or 2 hospitals with the potential to move to a 3rd hospital as things continue to evolve. The main hospital base is currently Harborview. That's where most fellows spend the bulk of their time. There is an opportunity at this point to go over on a Tuesday for clinic, on a Wednesday for the operating room to the University of Washington, and spend time with Viral Patel, and I'll introduce the various faculty later. Viral Patel also operates at Northwest, and in the future, as things are sort of evolving, Carlo Bellabarba and myself will probably also be spending some time at Northwest, and so there will be some opportunities down the road to end up at those hospitals as well. But right now, the primary base for where things are occurring is at Harborview Medical Center. And again, probably 90% of the fellows' time is spent at Harborview at this point in time. As we look at our current faculty and who you would be involved with, I'm the fellowship director. I've been here for, if you include my residency, I started here in '96. I did my finished residency here in 2001. I did my spine fellowship. I went away for a pediatric fellowship and been back on faculty since 2003. The chief of orthopedics at Harborview is Carlo Bellabarba. He has been here since, I think, 1999. He trained in Montreal, Chicago, Tampa. He's fellowship trained in both trauma as well as spine. And again, he's been here for 22, 23 years at this point in time. The other primary orthopedic spine person at Harborview is Haitao Zhou. He initially trained in China. He came over here, did a research fellowship in Augusta, did his residency in Augusta, did a spine fellowship here with us about 5-6 years ago now, and is on faculty with us here at Harborview as well. Viral Patel initially trained in India. He came over here to the US. Initially kind of started with a 2-year fellowship with us in spine, and then has gone on to do other fellowships in New Orleans, Minneapolis, and has been on faculty now for 2 to 3 years. He is based at the university, and Northwest splits his time about 50% at each facility. So those represent at this current time the orthopedic spine surgeons. Looking to our neurosurgery department and colleagues with whom we work quite closely, we have Fengyi Zhang. He did some of his training in China Medical School, came over here to the US for residency. Did his residency here, actually did a fellowship with us back in the mid-2000s, and has been on faculty here at Harborview for about 15 years. Randy Chestnut, he has been at Harborview now for about 15 years. He's sort of phasing out to some degree. He still takes spine call, but he's another person with whom you work. And then Rajiv Saigal has been here. He did his fellowship at UC San Francisco, has been here for 2 to 3 years now. Based mostly at Harborview, although he spends some time at the University of Washington. Christoph Hofstetter, he's based at the University of Washington, does a component of MIS, endoscopy. People don't work much with him, although there is an opportunity, particularly if your interest is in endoscopy. So hopefully that gives you a relative summary of the faculty who do spine surgery here. You should have also received a pamphlet, or that should be available to you from Carly. So you can cross-reference that and get more information if you want. You can also get some component of what people are interested in based on the research that is described in that manuscript as well. And look at that, and you can cross-reference with that. Moving on, if you look at our overall case volumes and case breakdown as we currently have it, I would say in any given year, we're doing close to probably 1,500 to 2,000 cases across the facilities. If you look only at Harborview, on the orthopedic side, between Carlo, myself, and Hightow, we're doing roughly 1,000 cases. If you add in Randy Fungi in particular, he represents probably 2/3 to 3/4 of the neurosurgery cases here. They're doing an additional probably 600 besides 1,000 we're doing. And then if you reach over to the university, they're probably doing 400, maybe 500 cases between University of Washington and Northwest. So collectively, we're doing about 2,000 cases. I think one of the aspects of our program that frequently is misrepresented is I think a lot of people come here thinking that all we do is trauma. And yes, we get a fair influx of trauma through our level 1 trauma center. We are the referral center for all of the Northwest, which includes Alaska, Montana, Idaho, and the state of Washington, with some extension across the Oregon border as well. So we certainly do get a component of trauma cases that come here. However, any given week, only one of us is on trauma call. The rest are doing their elective loads of degenerative stuff, deformity stuff, whatever else comes through the door. And so when we ask our fellows to break down their case log at the end of the year, if you look at the type of cases, only about 15% of them would fall into the trauma category. The rest are going to fall into other categories. So certainly a lot of exposure. We talk a lot about trauma because we're reviewing the cases that come in. In any given average summer day, there'll be probably 15 to 20 operative cases. If you throw in the non-operative, that can easily reach 30 to 35, even 40 cases during the summer. The winter tends to be a little bit slower, but still expect about 10 to 15 operative cases that come through the door. Mostly trauma, although we also get our epidural abscesses, our tumors, and various other things that are going to be coming in as well. So again, just to be clear, you will get a fair exposure to trauma here, but when you look at your case volumes and the case exposure, only about 15% of them end up being trauma proper. Everybody else is still doing, deformities. We are the referral center for that. We also get the tumors from around the country, not the country, but around the region. We get the epidural abscesses, the infections, for better or for worse. And then, of course, everybody has their generic elective, degenerative, deformity type stuff as well. So I think it leads to a good caseload. We cover things from occiput to the sacrum. We do stuff from the front, from the back, from the side. The whole gamut of stuff is available. And when I really kind of look at the advantage of the trauma stuff, it's pretty rare these days that you get to operate at the C1, C2 area, the occiput area, unless it's for trauma. On an average call week, I expect to get about 3 geriatric dense fractures and thus 3 C1, C2 instrumented fusions, which of course allow us to operate at the occipito-cervical junction and become very familiar with that. In fact, later today, I will do a C1 to T2 in a patient who has a 2-level fracture, one at C2, one at C7. Again, just a representation of what we do here. I think the trauma also allows us to do other things. We do a component of lumbopelvic instrumentation for sacral U or sacral AOC type injuries. So I think, again, it allows us to kind of work outside the bounds of normal areas that you would see in degeneration and deformity these days. Our fellows become very facile at placing screws from the occiput all the way down to the ilium. They become familiar with doing stuff from the front, from the side. We do a fair number of costotransversectomies. My last call week, I ended up doing 3 costotransversectomies, which our fellow participated in and actually did 2 of them with me assisting. So I think a lot of opportunity for various things to work on. We still run the staggered room sort of concept here. So I think, in terms of the fellowship itself, this is not an observational fellowship. We really rely on our fellows heavily to do a large component of the work. They rapidly ramp up and work independently. And so this is not an observer one. We do not have 2 attendings doing a case and the fellow kind of observing. We do have 3 PAs that work here with us. Aaron, Dina, and Joe, and they both have their strengths. Dina and Joe, particularly in clinic, Aaron in the operating room, but again, all very strong and very helpful in the operating room. At any given time, we have an R4 and an R2 on service for the spine, so they're helping to round and organize things, but also participating in the OR. But again, from a fellow standpoint, we are expecting our fellows to do a lot of work in terms of positioning, exposure, placing instrumentation. And usually within the first month or so, fellows, probably maybe 2 months, fellows are instrumenting most levels independently without much oversight. And of course, looking to the attending for backup. They're doing the decompressions frequently with a PA or a resident. And when it comes to TPLIF and inner bodies, they're also working with them in terms of just doing them themselves and being a significant part of that. So I think when comparing us to other fellowships, we're a very hands-on fellowship. We expect our fellows to do work. Looking at the breakdown of the week, on an average, we have 3 different rotations at this point in time for the 3 fellows, but the average breaks down to 1.5 days in clinic a week and 3 to 3.5 days in the operating room. One rotation has a Monday clinic and 4 days in the OR. Another one has a Tuesday, a Thursday clinic, and the other 3 days in the operating room. And the other one has a Thursday, Friday clinic, and the other 3 days in the operating room. So that's sort of how things look in terms of the usual clinic schedule. We do have an academic component to it as well. COVID has changed things to some degree. We typically have a journal club once a month. Ted Wagner runs this and is usually done at his home. And so that's on a Monday evening. Again, COVID has had an impact on that, so not as often. Carlo Bellabarba runs a lecture series where he kind of tries to cover things from trauma, occiput to sacrum, then through deformity, then through degeneration, through classification. And so that's usually done on a Thursday morning from 7:30 to 8:30. In total, that ends up being about 40 hours through the year. He doesn't do it quite every week, but pretty close. And so I'd say that bank on 40 hours of a lecture / discussion with Carlo with respect to that. The other thing that happens on Thursday morning is Carlo speaks from 7:30 to 8:30 or discusses. From 8:30 to 9, we meet with our neuroradiologists and discuss interesting cases. We teach them, they teach us, but it's a good time to interact with them and get to know them better. Friday morning from 7:15 to 8, we run a pre-op conference discussing all the upcoming cases for the coming week, indications, review the literature, make sure it's evidence-based, make sure we have all of our studies in place, but it's an opportunity to review those. About once a quarter, we will then also do an M&M where we discuss our complications and try and involve our anesthesia colleagues to try and get to the bottom. And it's meant to, yes, kind of check a box, but also equally to allow us to discuss how we should be doing things differently and those sorts of things. So that's hopefully gives a rundown. When we're on call, we do tend to have a sign-out conference. Again, COVID has had some impact on that, but that typically runs from 7 to 7:30 to discuss the cases that have come in from the night before and to make sure we have a good understanding, a good plan for all the patients that have come in, whether operative or non-operative. We do expect people, our fellows, to do research. That can be at the fellow's discretion in terms of their interest. Again, if you look at the pamphlet that Carly sent out, hopefully that will give you some perspective on some of the stuff that we have done in terms of research in the past. You can obviously look onto PubMed and see what else we've done. But really want you to come in with an idea. We have resources available. We have Julie Agel, who's our research assistant. She's very good at helping us with statistics, IRBs, running that sort of stuff. We have Jessica, who can help us format manuscripts and stuff like that. We have Celeste, who's currently our research fellow. So she's helping to spearhead a lot of things and run a lot of the, create a lot of charts and stuff like that. We try and meet semi-regularly to discuss projects and sort of update and troubleshoot and stuff like that. So in terms of asking people to do research, there are a lot of opportunities, but again, we have an infrastructure in place, so we're not asking you to kind of do it on your own. We have various fellows who are very interested in research and will do a number of projects. We have other fellows who sort of do the bare minimum. That's understandable based on where people are going, but the expectation is that people will be doing research while they're here to at least hopefully get one publishable project, maybe get involved in a book chapter or something like that. Kind of tailoring off of that, we are an AO fellowship or an AO funded fellowship. So with that, you have the perks of the AO in terms of there's typically a fellow course that's available for our fellows to go through in September. This last year was a little bit different, and so was done virtually over 6 to 8 weeks remotely via Zoom. But typically that's done in person, allows the fellows here to get to know other fellows across the country. There's a 3-day course, partly lecture, partly cadaveric, and then of course there's a business management component to it as well. With that, the fellows also have the opportunity to go to another course that AO sponsors, and the AO will cover that. And then of course, there's typically in March or April, the BAMP course up in Canada, where the fellows go and present their research, do case discussions, get to talk to fellow colleagues and stuff like that as well. So all that comes as an advantage of being part of an AO fellowship. There are currently roughly 50 others across the country. And so all those, we interact with all of them, and there's a lot to be gained by that as well. Some of the potential shortcomings as people may look at it, we kind of look at it as an advantage. We are not quick here to jump onto new technologies. We, I think, are relatively cutting edge in what we do, but we are not involved in a bunch of FDA trials looking at new artificial discs and stuff like that. We tend to kind of maybe not lag behind, but kind of wait for the evidence before we jump into that. So again, with our research, we are involved in a fair number of things, but in terms of if you're really looking for sort of the latest, greatest, newest stuff that people haven't heard about, we do not do a whole lot of that. Again, there's opportunity to kind of look into that, but some people look at that as a bit of a shortcoming. In terms of doing a lot of artificial discs and stuff like that, I personally do cervical and lumbar artificial disc. Most of my other colleagues do not. Some will do cervical on the neurosurgery side. So again, I think based on what you're looking for and based on what your needs may be, those may be some of the potential shortcomings. So hopefully that gives you a good oversight of who we are. Hopefully this gives you a little bit more information that as you plan on coming to our Zoom or interviews, as you look at the pamphlet that Carly has sent out, hopefully this will give you some more information in terms of who we are. And again, as questions come up from watching this, please write those down. I can try and address them when we discuss things online, or you can discuss them with the other faculty as well. So hopefully this has been helpful, and I'll look forward to hopefully talking with each of you in our individual interviews. Thank you very much.